Good morning, Greg. This presentation is intended to give you a sense of the story that I have to tell about dual practice in Israel, and with our mutual intention to write a paper together comparing how this issue is playing out in Canada and Israel. So this is, I guess, one of the three parts of the paper. This is about Israel. I imagine you'll do a piece on Canada, and then we'll have, I guess, maybe it's a four-part thing, an introduction which lays out the dual practice issue more broadly, and then a summary section that talks about what Canada and Israel experience can learn from one another. So, dual practice in Israel. So my presentation, and hence the paper, will have four main parts: an overview of Israeli healthcare, talking about the main form of dual practice in Israel, the problems caused by it, and the steps being taken to restrain it. So first, the main structural feature of Israeli healthcare. As you know, we have universal health insurance. We've had it since 1995. Everybody, every resident and citizen is insured automatically, and the system is funded by taxes. And every person gets to pick among four competing nonprofit health plans. Each health plan is required to give its members all the services specified in the governmentally determined benefits package. And the health plans get their money from the government based on how many members they have and their age mix. The hospital beds are owned about half by government and half by other organizations, which I'll talk about. I'll show you a graph in a minute. Our physicians, most of them work as salaried employees for either the hospitals or the health plans, but some work also on a contractual basis with the health plans, either capitation or fee-for-service, and then they retain this. They're not legally considered salaried workers, but rather independent contractors. And some also work privately. I'll talk more about that in a little bit. And the private side of things is growing in Israel, both in terms of the financing and the provision. Let me show you a few slides to put some numbers on these main points. So everybody has national health insurance, but there's also additional insurance in Israel, and one layer is supplemental insurance through the health plans. Almost everybody has that. The people who don't have it tend to be low-income people. And then we have commercial insurance, which is available through the private insurance companies. The same people that sell fire insurance and automobile insurance also sell additional health insurance. And just about everybody who has commercial insurance also has a supplemental insurance. They have dual coverage there. As you will see later, this private insurance, is a pivotal part of the story in Israel regarding dual practice. I said we have four nonprofit health plans. The largest one has about half the market share, and the second largest has about a quarter, and the other two are significantly smaller, but all of these are quite large organizations. Our population is about 8 million, so even the smallest health plan has almost 1 million members. The largest health plan has over 4 million members. The beds, about half the beds are in the acute or general hospital side, are owned by governments. The largest health plan has about 30% of the beds. Most of the rest are in the other nonprofits. And in terms of beds, our for-profit hospitals are a very small part of the picture, only 3%. Later in the presentation, I'll be showing you their much more significant role when it comes to operations. Now, the physicians, most of them work only as salaried employees, 70%. Another 7% work only independently. That's either totally independently, but more often as contractors on a fee-for-service or a capitation basis with the health plans, or on fee-for-service basis with a private hospital. But there's another 23% that does both. In the next slide, you see a little bit about physician incomes, we see that in 2012, the median physician was salaried earned in the course of the year 291,000 shekels. That's up by 41% from the situation 4 years earlier. There's been a big increase in physician incomes recently. The independent physicians tend to work fewer hours, and we don't have. I'll try to get data on the number of hours they work. I don't have it in front of me now, but their average or median income was $239,000, and that has gone up a lot. But the group whose incomes went up the most are the people who both salaried and independent in both of those years, and their incomes went up by over 100%. I mentioned the growth of the private financing, and if in 1995 we were around 30%, now we're pushing 40% private finance. And now a few comparative statistics to put the Israeli situation in context. I'll go through these pretty quickly. In terms of health as a share of GDP, we're relatively low. We're under 8%, much less than the US, UK, and Canada. Since we're giving the talk, I think, in a conference in Singapore, I'll add the data for Singapore when I can find it. And if we're having a conference somewhere else, tell me and I'll add that country's data. Israel's even lower when it comes to Israel's relative position is even lower when it comes to per capita spending, because also our GDP per capita is lower than these other countries, and we're at around $2,500 per year, PPP. The OECD also has data on the share of total financing, which is from governmental or compulsory health insurance sources. So we're above that of the US, but we're below that of UK, Canada, and the OECD average. And in terms of life expectancy, we do quite well, which suggests, and also on other key outcome parameters such as infant mortality and others. So the general sense is that Israel is considered an efficient healthcare system. Bloomberg's put us about 8th in the world, and another recent ranking also put us around there. Now in Israel there are several forms of dual practice, but I want to focus on what I'm going to call the main form. In the main form, we're talking about doctors who are full-time employees of government or nonprofit hospitals. They're paid to be full-time there. They're paid on a salaried basis, but they also, in the late afternoons or evenings, go work. In addition to that, they work in a private hospital where they're going to work typically on a fee-for-service basis. This is happening most often with surgeons. The care received in those private hospitals is being paid for not by national health insurance, and also not by out of pocket usually, but by the private insurance, either from the commercial insurers or the health plan supplemental insurance. Now, why do patients go to get care in these private hospitals? They do it partly to reduce the waiting time for their operations, which in some cases can be quite long in the public hospitals. They'll do it to be able to choose their surgeon, because in the public hospitals, the surgeon is assigned to a particular case by the department head. Patients don't get to pick. And patients will also go privately because they expect, and probably it's true, that the surgeon will talk to them more, both before and after the operation, and they'll get more personal attention. As I mentioned before, the private hospitals only account for 3% of the beds, but they focus on operations and on on elective operations, because those are the most profitable segments of hospital care in Israel under the current reimbursement system. So while they're only 3% of the beds, these private hospitals, they have 12% of the operating rooms, and they have almost 40% of the elective procedures. Now, even within the elective procedures, they will focus on the younger patients because they have fewer comorbidities and are more profitable. And the private hospitals, when it comes to the 75 plus age group, they'll only have 13% of the elective operations. They're also growing quickly. The only period for which we have data on this is 2007 to 2011. In that period, the number of operations grew by 19% overall, but almost all the growth was in the private hospitals, which grew by 58%. As I mentioned before, there are some additional forms of dual practice which won't be the focus of our paper, but I'll just mention them briefly. First, in some of our nonprofit hospitals, particularly in Jerusalem, they are the only ones allowed to sell private services from within the public hospital. It's a historical artifact, and It has not been changed. And so what happens is that if I just want to get regular care in those hospitals, let's say Hadassah, I can go through my health plan. The health plan will pay all the costs, and I won't get to pick my surgeon. But if I want to be able to pick my surgeon, I can also do it at Hadassah. The health plan will pay the basic amount, and I will pay the difference, usually from my supplemental or commercial insurance. And the doctor who in the morning shift works on a salary basis, dealing with public patients, in the second shift will deal with these private patients on a fee-for-service basis. Another arrangement is in the government hospitals. They have a somewhat similar arrangement. There too, there's a second shift in some of them to deal with operations for which there's a long waiting time. And there too, the physician can make money for those additional work, fee-for-service, but there it's not paid out of the private payments. It's actually paid through the health plans. And the health plans pay the hospitals for this at a per case basis, and it's usually more lucrative for the hospitals than the basic service, than the usual service, but it's not as profitable as the private arrangement that they have in the Jerusalem hospitals. And a third type of additional dual practice is that many of the physicians or the specialists working in the hospitals will also work part-time in the late afternoons for the health plans. So they work in both arrangements, in both settings they're working for a nonprofit provider, but it's still two types of different practice. So those are the additional forms of dual practice, but our biggest issue in Israel is with this main form, and that's what I'm going to focus on. So just to repeat, it's the doctors working full-time in a government or nonprofit hospital. They'll also work privately in the late afternoon or evening on a fee-for-service basis, and it's being financed through a private insurance, commercial or supplemental insurance. Now, this type of dual practice creates some major problems for our system, and I'll mention 6 of them. One is the senior physicians are leaving earlier. Otherwise, they would have stayed in the hospital complex doing research, doing teaching, so we have less availability of these senior physicians. And this has also reduced the confidence that the public has in the publicly financed system. And they come to feel that if they really want to get good care, they have to go privately, and therefore they should buy private insurance. There's also, it puts pressure on the wage levels because the public system has to compete with the private system, so it has to make it worthwhile for these doctors to stay primarily in the public system, so that increases the cost in the public system. It also makes it difficult to get doctors to go into specialties where there's no private practice. Let's take, for example, primary care or pathology, right? There's not much private practice there. So once there is more private practice opportunities, young physicians are going to go more into surgery or to those things where there's private practice. And the private practice is mostly in the central part of the country, so it's also a disincentive for young doctors to do their residencies and then go on living in the peripheral regions of the north and the south. This dual practice also reduces health system equity because the people who have the money through their insurance, the people who have the money to buy private insurance and hence have insurance to pay for the private care in the private hospitals are the other wealthier people. So this, obviously, they're getting a different level of care, shorter waiting times, more personal attention, and choice of physician that the others might not be getting. And finally, this is affecting our public hospitals, which are our mainstream in terms of dealing with the difficult situations, the unattractive, the unprofitable sectors of care, the education of the coming generation of physicians, because more of the care is going to the doctors working in the private hospitals, and the health plans, the public hospitals therefore don't get the revenue from those patients. Now, Israel's starting to take some steps to deal with this dual practice, either to make it less common or to, where it does exist, to make it less problematic. So I'll mention 5 key steps being taken. One is that the public hospital physicians are being required to clock in and clock out, so they can't fake it. They can't pretend that they're there when they're not there, and they're required to work a certain amount of hours per week, let's say 40 or 45 hours per week, so that they can clock in and clock out through their smartphones. So there's a certain amount of trust built into at the basis of this arrangement. Of course, the doctors hate this, and even those who aren't cheating feel that they're being reduced to being workers, proletariat. So we'll have to see how that plays out in the future. Another major effort is being launched as we speak, where physicians in the public hospitals who are willing to commit not to work at all privately and to work additional hours, usually an extra 12 hours a week in the public sector, they'll get big bonuses. And I'm talking about really big bonuses. So if a typical hospital, they're targeting this program at the young board certified physician. So someone who doesn't yet have a private practice, and because the sense is if you try to get the really superstars, it's too late to get them. They made so much money already that there's no way to pull them back into the public system exclusively. So with these young board certified physicians, maybe they're in their mid to late 30s. If they would ordinarily be getting 25,000 shekels a month on their salary, they might get an additional bonus. They might get additional 15 or 20,000 for signing on to this program. Another thing that's put in place is that if you see a doctor sees a patient in the public system, whether it's in a hospital or in a health plan, he cannot say to the patient, "Come see me privately." There has to be I think, a gap of at least 3 months between when you see a patient in the public system versus when you'd see him privately. Fourth and fifth are things not targeted specifically at dual practice, but would have effect of reducing dual practice. One is just to make the public hospital system stronger. If the public feels the public hospitals are better, they'll buy less private insurance. They'll go less to private hospitals. There'll be less work there for private physicians. And one of the ways they're trying to strengthen public hospitals is by giving them extra money in return for reducing the surgical waiting times. And so they're strengthened both by having shorter waiting times as well as by having more money. Another thing, the fifth item, is they were trying to, in parallel, reduce the growth of private insurance, and there's quite a number of different steps there, but one of them is to reduce the dual coverage. Many people have both supplemental insurance from the health plan and commercial insurance from the commercial insurance companies, and oftentimes there's a lot of overlap there, and the insurers are making tons of money from that. And they're taking steps to standardize the benefits package so that people won't get insured twice for the same thing. So that's my overview, Greg, and I'm happy to take any comments or questions you may have. Thank you.